There have been data. There's been my graduate student, Dr. Ruthira Kuhan, did a Cochrane review of all the treatments for apathy to date. First, we would look at cholinesterase inhibitors, which are the standard treatments for Alzheimer's disease in most countries, including mild, moderate, and severe. If you look at those data, apathy was only considered as a secondary outcome. So there is not strong evidence, but it does show that there is a small effect on apathy. Other studies have shown that if you follow people over time who are on cholinesterase inhibitors, there's a decreased emergence of apathy. So I think that it may have a small impact when you're trying to treat apathy, but really its effect is helping people not have an emergence of apathy over time. The same with methylphenidate, the treatment for moderate to severe Alzheimer's disease. If you look at the studies that combine in people with moderate to severe Alzheimer's disease, there was a publication that combined 6 different trials, and even combining those trials, if you look at apathy, there's no significant difference between the Memantine group and the placebo group. So we don't think that there's an effect of Memantine. It may help with the emergence of apathy over time. There is one study that's looked at Aducanumab from the emerge trial that looked at over 1,600 patients. It did have an effect on neuropsychiatric symptoms overall, but if you look at the apathy subscale of the neuropsychiatric inventory, on the apathy subscale in particular, both groups got worse. So the placebo just worsened more over the period of observation than the Aducanumab group. So again, we're seeing the same pattern, that it may help with the emergence of apathy, but it's not necessarily a fantastic treatment when apathy is there. That's why it's important that we start running clinical trials that focus on apathy as a symptom. So recruit everyone with apathy and not just look at it as a secondary outcome. And that's what the ADMET-2 trial did. It recruited patients who actually all had clinically significant apathy and added on the treatment to a psychosocial intervention. We've also analyzed the ADMET-2 trial to look at predictors of response or non-response to methylphenidate and placebo. First, to analyze that, we looked at 21 potential predictors of response, and we narrowed it down to those that had made a difference of at least 2 points on the MPI apathy subscale. And we found that dividing patients into tertiles, individuals were more likely to benefit from methylphenidate treatment compared to placebo if they had less anxiety and less agitation at baseline, more education, that they already had treatments in place for Alzheimer's disease like cholinesterase inhibitors, and they had lower functional capabilities. These data might be important in the future for helping determine who may or may not respond or understanding non-response.